Good afternoon. We have with us Dr. Saibal Chakravarti, intensivist at GT Hospital, Kolkata. We welcome you to the Natco Pharma Specialty Studio, and we look forward to listening to your words of advice to the young generation doctors. Those are associated with special critical care and bacterial resistant treatments. Uh, what, as per you, is the changes you have foreseen in critical care management or treatment?
In fact, myself being a member of Critical Care Society since 97,
Wow.
so we have seen a whole gamut of change. Uh, Omnatax, Clafuran was the antibiotic, and that was supposed to be the jewel in the armamentarium of antibiotics. And nowadays, we have come back so much. But as we understand, the pipelines are being dried up. So we have to be cautious, as well as India being a tropical country, we are famously known for all the tropical infectious diseases. So we are very tempted to use antibiotics. Sometimes maybe due to our social habits, we are not hygiene, we are not so aware of. So all these things put together, we have a lot of burden of infection and critical infection in our country.
Oh, so it's good that you mentioned that much of the time from '97 you have been witnessing these changes. What is the biggest message you want to give the young ICU doctors who are in patient care? What's the best that they can do?
There is a dilemma because in critical care, now we have a concept that hit early, hit hard. But that is also a fact. A lot of community acquired pneumonia, viral pneumonia. Perhaps we don't need any antibiotic. Perhaps they are sick, little hypoxic, family is worried, elderly or very young, put into the ICU. So that is one foremost reason people are, our leaders are advocating to prevent antibiotic resistance and reserving our last armamentarium, say like ceftazidime, avibactam. So to use them sparingly, and but in a very selective case, very high, and perhaps biomarkers of sepsis has to be used more so that we cannot, if not give within 1 hour, maybe we can, if we can start it within 4 hours.
What is the prevalence of carbapenems in your practice, and what treatment options would you?
Very big, very big. As we say, when we started, in fact, that is differs from hospital to hospital. Each hospital should have an infection control policy and their own resistance pattern. Like in our hospital, we always knew that third generation cephalosporin are getting more resistance. In our audit, we found that piptazo is also quite resistant. So we started using more meropenem. ऐसा हुआ कि मैं नाम नहीं बताऊं, meropenem लिखना must हो गया. We must use meropenem. So, but that is not a happy situation. So, yes, if we get such a thing, if it is community acquired, I will still not use the best and possible the last resort. Uh, in fact, one of the slides we saw that हमने बोलते थे मच्छर मारने के लिए कामान दाग देना. In one of the slides in the hall today, we saw that instead of hitting the mosquitoes with a cannon, hit the target with an arrow. So we should prefer to do that. But yes, we should also remember that I have a cannon in my armamentarium to kill the enemy.
Wow. Uh, I love the analogy that you have shared right now. And we thank you so much, Dr. Chakravarti, for your time in the studio this afternoon. And we wish you all the best.